Uh, Thank you, Patricia and McGill to give me the opportunity to present about right-based existential psychiatry and deep therapy, something I've been working on in the past couple of years. And I want to take the opportunity to thank McGill for being my alma mater, meaning my second mother in terms of education, work, everything in the past 13 years. I've done everything at McGill. So just quickly about disclosures, I have nothing to disclose. The only thing I need to say is this what I'm presenting is currently under peer review, so it's more about a research, a scholarly work that I'm interested in. And I'd like to read the last point that do not expect formal academic logic here. It will not serve you. This is more about presentation on empathy, clarity of experience, and attempt to see the lived experience of our patients existentially. So the content of what I'm going to present, I try to be short. I usually not. I tend to talk a lot, but I try to give the core message of it's the most important factor in mental health care is to know the person in front of you and let the patient in front of you know you as well. So that's the key message of existentialism. So for that, I'm going to present a little bit about the human rights, definition, history of human rights, a little bit about existentialism, definition, background, the implications in mental health, and then the two concepts that I'm trying to introduce by mixing right-based existential psychiatry, by mixing human rights and existentialism to create right-based existential psychiatry and deep therapy, dynamic, eclectic, existential psychopharmacotherapy. Now, first, who am I? I started without introducing myself. I assume that most of you know me, but that's the wrong assumption. A lot of you don't know me. I'm Artem Madanian, uh, originally from Iran. I was born and raised in Tehran. This is a picture of me in my junior secondary school, just age 15 probably. Two friends that I don't know what they are doing right now. And then I did my medical school at Tehran University. Uh, Medical school in Iran is right after high school. And the second picture with the scarf, flag of Quebec, shows the power of obsession because when I was towards the end of my medical school, my mom and sister, they watched the movie of Ben Carson and Johns Hopkins, and they tried to tell me that you have to go to Johns Hopkins. You're a great, student and medical student. But I couldn't speak French and I couldn't speak English, and I knew there's a place called Quebec and McGill that they speak French and they speak English, and that's great. And I said, I'm going to McGill. So I asked my aunt to create a flag of Quebec, and I was walking everywhere in my hospital and my lab coat with that. So far before I immigrated to Canada, I was obsessed with Quebec and McGill. And then I graduated as a GP. I worked in the border of Iran and Pakistan in a very rural area. It's a place that really doesn't have nothing. I was the only physician for 100-kilometer border, 100-kilometer radius area. And this is my picture with Baluch people who are part of Iranian community with some banana trees. For a short while, I worked as internationalization advisor of Chancellor of Tehran University before applying for immigration. And then when I got my immigration visa, I worked as a train doctor in Iran. I don't think if it exists anywhere else. You sit in the train, you go to remote areas where there is no access other than train. There are areas in Iran, mountainous, that only train can go there. And you go, you provide healthcare to those areas of remote. That was the opportunity to visit all over Iran. So now, I'm from Iran. These days, everybody hears a Strait of Hormuz when they talks about Iran. But Iran is not only a Strait of Hormuz. It has a lot of historical place. It was home to Zarathustra, Zoroastrian religion, and host to a lot of other religions like Christianity, Islam, and other nations who came to Iran. And it's a really multinational place. What do I do now? I work at McGill, definitely. I have a home office based in Washington, D.C., so I'm based between Montreal and Washington, D.C. I provide consults in a pain clinic, and I do some locum work, dépannage, north of Quebec and Iqaluit, Nunavut, which is fun and also providing healthcare where it's needed. Now, given my background working in different areas, I came into understanding that human rights is an important aspect of healthcare, the social determinants of health. People whose human rights are violated, they have higher chances of getting problems in healthcare. So I got to learn a little bit more about what's human rights in mental health and psychiatry and healthcare. And I want to keep it very short and brief for the sake of today's presentation. But we know that human rights have started from, again, Iran, Cyrus the Great, freeing Jews from Babylonian and the first Charter of Human Rights. But the main human rights aspect really started after the World War II because there were a lot of human rights violations during the war. And the United Nations presented the Charter for Human Rights. Human rights entered healthcare and psychiatry, mental health care by CRDP, Convention on the Rights of People with Disabilities, that was introduced years after the Charter of Human Rights. And the main message of CRPD was that the rights of people with disabilities is the same as the rights of other people. So what are the key elements? Autonomy, the main thing in human rights for healthcare is autonomy, informed consent, involving patients in the decision making, non-discrimination, dignity and respect, participation. Patients should be an active participant of care, even when it comes to medication management, to choice of medication. The patient should be able to participate. And then bigger aspect of human rights are availability, accessibility, acceptability of care, and the quality of care that we provide. So if we include human rights in mental health care and psychiatry, the outcomes will be that we should provide a person-centered care, recovery-oriented approach. It's not only about disorders, it's also about recovery. And supported decision making instead of substitute decision making. It's in any cost, the patient is the one who makes the decisions. And the most controversial aspect is abolition or limiting coercive measures in psychiatry. Now, quickly about existentialism. We can talk hours about existentialism, but I want to be very quick. Started with Kierkegaard when he introduced the option that you can choose to believe in God because there's no evidence that there's God or not, and brought up the idea of choice and responsibility and consequences. Kierkegaard said that the anxieties that we have are dizziness of our choices because we have multiple choices in life and we get anxious about what to choose. Then Friedrich Nietzsche talked about the will to power, and we get despair and disappointed because there are no moral facts and there are no absolute meaning in life. So we have to find our own meaning. But then existentialism entered the realm of mental health and psychiatry by Rollo May, who introduced the idea of existence and existential analysis. So somewhat around the time of Freud or after Freud, Rollo May said that you can analyze any kind of human behavior by how they respond to existential questions. So it's not about Oedipus complex or how your father or your mother treated you as a child. It's about how you respond to the fundamental questions of life. And what are these fundamental questions of life? Irving Yalom put them into four categories, called them givens of existence. Freedom, choice, responsibility. We are free. Schopenhauer said that our freedom is limited, so it's not that we are free to do whatever we want to do, but we are free to choose from what options we have in front of us. And we have choices every morning from the moment we wake up. We have a choice to come to work or show up to work or don't show up to work. We have a choice to be nice or not to be nice. Then meaninglessness and search for meaning. Uh, Viktor Frankl, the psychiatrist who was in Auschwitz, he found out that people who had a meaning, a reason to live, to survive, they had a higher chance of survival in Auschwitz. And then he created logotherapy, meaning therapy, just looking at the meaning. Then we have isolation and relational longing. So we as human beings, we are isolated being on earth. There's a notion of uh, Goverfenheit, that we are thrown on earth and we are born alone, we die alone, and we long for connection with other people. And there's always a battle, a conflict inside for a wish to be connected to others and a fear of becoming vulnerable when we are connected to others. So that vulnerability when we are connected, when we are known by others, is a fear that stops us. And the ultimate fear of human being, death, mortality, finitude, we all will die. Thinking about it, you work, you fight, you try, you argue, and then you die. And you don't know what will happen or if anything happens after you. Just definitely your loved ones will mourn you. But what else happens after you die, nobody knows and nobody can prove it. So as you can see, a lot of these questions and uh, concerns in existence are very fundamental. And if you think about them for 5 minutes, you will have some consequences. Either you will have angst, you will feel worried, or you will be despaired, or you will face a lot of uncertainties that what is this? Why are we here? And what are the possible responses to these questions? So if you feel the angst, you will have anxiety. If you feel the despair, you will have depression. Uncertainty, you might try to rebellion in psychiatric term, manic episodes, psychotic episodes. That's a type of revolt and rebellion towards existence. But there is also another possibility of response. And that possibility is the possibility of enhanced capacity for reflection, self-awareness, and growth, becoming an authentic self and meaning making. So the same questions, the same concerns that can make you feel anxious, depressed, worried, or manic, psychotic, they can also make you feel authentic, having a meaning in life, and becoming a grown up, self aware person. So that's why a lot of philosophers, including Rumi, the Persian philosophers, I'm taking the opportunity to advertise a lot about Iran today. Rumi says that the growth and heaven enters from a wound. And by wound, he means the just psychological traumas that we are talking about. So he's talking about post-traumatic growth rather than just focusing on post-traumatic disorders. So now, talking about human rights and existentialism, I found out that they have a lot of common grounds. Human rights talks about autonomy. Existentialism talks about choice, freedom, responsibility. So I said we can mix this, create a new model, a new approach of looking at mental health, and I called it right-based existential psychiatry. So it looks at the common grounds and complementary aspect of human rights and existentialism. It integrates principles of human rights as the framework and the elements of existential philosophy as therapeutic approach. So the main elements in right-based existential psychiatry is that you treat persons, not symptoms, not disorders, not uh, mm, conditions even. You treat persons. And our own William Osler, that I followed his path going from McGill to Johns Hopkins for my fellowship, Osler said that a good doctor is a doctor who treats the person in front of him, not the disease that he sees. So human rights provide the ethical structure for this framework, and existential psychiatry provides the philosophical depth and psychotherapeutic aspect. The focus will be on inherent dignity of human being and our patients, autonomy of our patients to choose what they want, authenticity, and their capacity to grow. So we are not looking at conditions, we are looking at people who can grow. And then in the interaction, the most important factor is therapeutic relationship with the patient. The patient grows through a therapeutic relationship with the therapist. And through this therapeutic relationship, we can address the concerns about isolation, meaning, death, and responsibility and choice. Uh, so the goal is to help the patients answer the challenges, fundamental existential questions, and help them be able to find their place in the world. Who is right-based existential psychiatry good for? I say that existential approach is good in any situation, being authentic, being another human being. Martin Buber, the philosopher, presented the two kind of encounters between physician and patient. I and you encounter, that the physician is the person who knows the answer, and the patient comes to get the answer. And he says that that type of relationship is not healing, is not helpful. And the second type of relationship is I and thou relationship. And that's a relationship that is equal. There's no hierarchy. I don't know the answers. We are trying together to find the answer. So we are both journey travelers on this existence with a lot of uncertainties, imperfection, and we try to find the answer for you. Maybe in surgery, that's not going to work to be I-thou relationship with your patient, but in psychiatry, definitely it works if you have a non-hierarchical relationship with your patients. So the existential encounter works for any encounter, even in emergency, even in surgery. But the right-based existential psychiatry approach might be better for people who feel alienated by traditional psychiatry. They are not looking into symptom management. They are more looking into whys. Why am I experiencing this? How can I change? How can I improve? There are people who just look at psychiatry and mental health as biology, neurotransmitters, and there's nothing beyond that for them. So that's not going to be the best approach. And in summary, right-based existential psychiatry aims to honor the human rights, existential concerns of individuals, fostering a therapeutic relationship that is ethically grounded and attuned to deeper dimensions of human experience. It moves beyond just treating symptoms, emphasizing the importance of a person's right to self-determination and their search for meaning in life. And as you see, therapeutic relationship is bold here because that's the main and most important factor. Now, if we believe in or accept right-based existential psychiatry as a framework, we need a therapeutic model for that. We need something that we can deliver clinically as clinicians for our patients. I thought about eclectic way of looking at things because I started eclectic by mixing human rights and existentialism. So dynamic eclectic existential psychopharmacotherapy. You see, the name is too difficult to pronounce. I myself cannot pronounce it well sometimes. So I said that acronym, deep therapy. But deep therapy is not super deep. It stays as superficial as possible to help because as Chichek says, if you go deep enough, sorry for my language, there is only shit deep inside in all human beings. There's nothing more than that. So you should not go too deep in psychoanalysis, but you should be deep enough to help people. And then eclectic, because as Carl Jung said, if you want to help the person, you cannot adhere to one school of practice. You know, when a doctor tells me that he adheres strictly to this or that method, I have doubts about his therapeutic effect. You cannot treat everybody with CBT or everybody with psychoanalysis. The answer, the solution to the problem is always individual. So I'm very much pro individualized care. For individualized care, you should accept eclecticism. Eclecticism means not adhering to single model, integrating techniques, theories, principles from different various therapeutic models. You don't need to be expert in all, but you need to know multiple models to be able to use them. Again, eclecticism helps being patient-focused, patient-centered, being flexible, adaptable. You're not following, just one school of thought. You use different aspects of different schools of thought. And it's empirical, pragmatic, and focuses on common elements and common goals of psychotherapy. What are common elements of psychotherapy? I think you know better than me. Therapeutic relationship alliance is the most important and most predictive factor in psychotherapy and in medication management. There's a very nice study that says that what predicted the outcome of antidepressant was therapeutic relationship between the psychiatrist and the patient, not the choice of antidepressant and the type of antidepressant. What is therapeutic relationship? Mutual trust, respect, collaboration, empathy, warmth, genuineness. Be vulnerable with your patient and have a goal consensus. The second common element is hope and positive expectancy. That's, I think, something that is missing in Western and, well, I call it Western, but modern medicine, psychiatry. And it exists very well in traditional healing. And that's why it works. You go to a traditional healer or a herbal medicine doctor, and they instill hope. They instill positive expectancy. They are sure of their treatment. There's no evidence that it works, but they are sure of it. And that's why it works for some people. That's why it's still traditional healing, herbal medicine. In Montreal, you go, there are traditional healers that they have more clients than psychiatrists. And that's because they instill hope. Wrong or right, it works for some people. But we have lost that. We say that, okay, you have a schizophrenia, you're done. Your life is done. But that's not the case. Even the WHO evidence says 60% of people with a diagnosis, schizophrenia, they can have a functional life. They can get back to work. They can stop having any other episodes in their life by proper treatment and management. And then we have the therapy's factors of flexibility, adaptability, and patience factors. And common goals of psychotherapies, creating metacognition and insight, psychoeducation. I put insight into parentheses because for existentialism, insight is not very much helpful. That's the same. Going too deep, that is not going to help at all, unless you want to just know yourself. But psychoeducation is skill training, cultural sensitivity, behavioral activation, meaning making, clarifying values. These are all different aspects of common goals in different psychotherapy models. So deep therapy is supposed to be a transdiagnostic, eclectic, patient-centered approach. It offers a structure to deliver personalized, ethically grounded, right-based, culturally sensitive, and existentially attuned care. It has 7 nonlinear core modules. I will show the modules in the next slide. But the modules are not it's not like DBT that you need to do all the 4 modules. It's like these modules should be in the mind of the therapist and applied accordingly in each session. Each element and each module is grounded in evidence-based practice, but the innovation is unification of them and combination, integration of them in a shared commitment to respect patients' narrative choices and meaning making. So these are the modules I'm talking about, and I want to be also cognizant of time. So the acceptance draws on acceptance commitment therapy, dialectical behavioral therapy to support mindfulness. As you can see, the deep therapy modules are A, B, C, D, E, F, G. So the 7 modules go alphabetically, but they are not linear. Acceptance is the core, and existentialism is the frame. The rest are things that you use according to the situation. So B stands for behavioral change. It focuses on collaborative, values-oriented actions informed by behavioral activation, exposure-based approaches. C stands for cognitive restructuring. It's based on cognitive behavioral therapy, looking at thoughts, not in terms of positive, negative thoughts, not in terms of changing thoughts, but in terms of understanding thoughts and trying to find together with our patient what thoughts are helpful, what thoughts are not helpful. It's not right or wrong. It's not true or false. It's only the matter of helpful or unhelpful, because maybe some unhelpful thoughts, they might not be wrong, philosophically speaking, but they are not helpful. So that's the way to, so the cognitive restructuring is also has some existential tone into it. Then D is dynamic analysis. As I said, I firmly believe in psychoanalysis and psychodynamic in terms of meaning and reasons, but I don't believe that it's super helpful for the patients to know why they do what they do. But it's important also to incorporate some psychodynamic, psychoanalytic perspectives into practice, understanding the attachment patterns, understanding the relationship, the therapeutic relationship, transference, countertransference, and some unconscious processes, but it's not the main focus. Existential exploration, that's the main focus of the frame of this deep therapy model. I will have another slide about that. And then find focused pharmacotherapy, which is a way of looking at medication as a help, not the final tool, not the only way to treat or to cure the patients, but evidence-based, evidence-informed use of medications, the lowest possible dose, the fewer medication possible. And then eventually grounding techniques, which is using of somatic, sensory, cognitive techniques to deal with the episodes and attacks of anxiety and despair in life. Now, existential approach, as I said, it's the main domain central to deep therapy, confronting the conditions of existence, and it's not being shy to talk about death, mortality, what's the meaning of life, what's the meaning of death for the patient. In face of, there is a sentence by Irving Yalom, it says, in face of death, any other trauma is nothing. And when people think about their death, they can go high enough that they don't see any other traumas as traumatic in their life. So it's important to be able to talk about those matters. Now, for the sake of today's presentation, I tried